Very good afternoon, everyone. So we'll begin the session on squint. Already we are running late and we are two speakers. So I am Dr. Gunjan and I'll be talking on monocular elevation deficit. And we have on our dais Dr. Minakshi, who is from Arvind Eye Hospital, an eminent strabismologist. Uh, so to begin with, I'll be talking on monocular elevation deficit. So it is the limitation of elevation of the affected eye with normal inductions in all other cases, and this limitation in elevation is present both in abduction as well as in adduction. It is frequently associated with ptosis, pseudotosis, Marcus-Gunn jaw winking phenomena, and has a vertical deviation which is usually associated with it. So, according to Ziffer et al., depending on the underlying etiology, it has been classified into three types. Where type 1 is caused because of the inferior rectus restriction that can be a result of either trauma or it can be because of autoimmune diseases like sarcoidosis or can be a result of thyroid eye disease at times, and the type 2 MED results from superior rectus palsy, which can be because of congenital causes, post traumatic causes, and MED3 results from the supranuclear causes, again, that can be post traumatic or can be because of the neonatal hypoxia. So, I'll be discussing some of the cases of monocular elevation deficit, and based on this, we will be discussing how do we approach these cases. So, this is one of the patient. He's a 15-year-old male. He presented with severe congenital ptosis. Along with that, he had a hypotropia. There was Marcus-Gunn jaw winking phenomena, and there was elevation deficit with hypotropia. So the initial plan was to do the forced duction test, and on forced duction test it was found to be positive for inferior rectus, and hence the plan for inferior rectus recession was made. An inferior rectus recession of 5 millimeters was done, and this improved not just the hypotropia but also the ptosis of the patient, as we can see in this image. Similar case was with a 20-year-old male. He had a history of RTA, and following that he developed limitation of movements in the up gaze. On NCCT we found that the inferior rectus was not entrapped and there was no evident orbital fracture. There was a hypotropia of 25 prism diopters in primary. So a forced duction test was done for inferior rectus and it was found to be tight. Again, an inferior rectus recession was 5 mm was done. There is a reason why I am limiting to 5 millimeters, and that is because if we do it beyond 5 millimeters, there is a risk of lower lid retraction. And this is another case of a 25-year-old female. She had cysticercosis on her CT scan, and FTT was tight for inferior rectus. Following that, inferior rectus recession of 4.5 millimeters was done. So this is the pre-op 9 gaze and the post-op 9 gaze, which clearly shows the improvement in the elevation in this patient. Now, these were the one variety of cases where the inferior rectus was tight. Now, the second variety of cases are those where the inferior rectus will be free. So, this is one such case where a 20-year-old female presented with complaints of elevation deficit with drooping of left upper lid. Again, she had a complex ptosis with Marcus-Gunn, and she had a vertical deviation of 25 prism diopters. Along with that, she also had a horizontal deviation of 50 prism. Her forced duction test was free, and hence the plan was a modified NAPS procedure correcting both the horizontal. In order to correct the horizontal deviation, a horizontal muscle recession resection was planned along with its transposition. So this was the pre-op and the post-op of the patient, showing an improvement in the hypotropia as well as slight improvement in the hypotropia as well as the improvement in the elevation was seen. The bells definitely improved, and following that patient underwent a ptosis surgery also. So this was another similar case where the patient had a stage surgery, first for the correction of squint, and following that she had the surgery for her ptosis following the improvement of bells. Now, this is another case of type 2 monocular elevation deficit where the inferior rectus was found to be free, and hence the plan, because the patient had esotropia, the plan was medial rectus recession along with lateral rectus resection and superior transposition, and we can see the images that there is a gross improvement in the elevation deficit as well as in the horizontal deviation too. and another case of type 2 monocular elevation deficit where the similar plans were done. So, if you look in a algorithm, in a gist, so first of all, the indications of surgery in monocular elevation deficit, as we saw in all the previous cases, was there was a very large vertical deviation, there was amblyopia, there was anomalous head posture, patients wanted correction of ptosis, they wanted improvement in the bells, and so we opted for these surgeries. Second thing is, how do we approach? So, the first thing, whenever you are planning the surgery for MED, is to go for a force duction test. If the force duction test for FDT is free, then you can plan for a NAPS procedure. And if it is tight, then inferior rectus recession up to 5 millimeters can be done with slight nasalization to avoid any pattern in the post-op. However, if it is free, then go for a NAPS procedure, and if the horizontal deviation is also present, go for a modified NAPS. That means you resect the muscle and then you transpose it. The another viable option in these cases can be modified Nishidas or contralateral eye surgeries. Coming to the effectiveness of various surgical procedures, that will be in for inferior rectus recession, the average correction that has been reported in various studies ranges from 12 to 16. For NAPS, it ranges from 29 to 38. However, in patients with large vertical deviations, you need to sometimes put a suture in the horizontal muscle that is said to be an augmented NAPS, and it is said to be correcting 30 to 40 prism. The modified NAPS procedure corrects a horizontal deviation of up to 20 and vertical deviation of 25. And as I told, modified Nishidas, there has been a small case report and few case studies which report that it can correct up to 30 prism diopters of vertical deviation. So, and my observation, one has to be careful with inferior rectus recession. Inferior rectus recession per se cannot correct more than 20. Each millimeter of inferior rectus recession corrects around 3 to 3.5 prism diopters of the vertical deviation. Excessive inferior rectus recession can lead to lid retraction. So, if you have any inferior rectus that is tight, along with that, if you are planning the surgery, you might add up superior rectus plication or superior rectus resection to that. You might need to even to perform NAPS or augmented NAPS after an interval of 3 months just to prevent the anterior segment ischemia. Modified Nishidas, as I had stated earlier also, is a safe option because it's a no tenotomy, no splitting technique where you simply have to pass a non-absorbable suture 12 mm from the limbus in the superior quadrant. But long-term results are still not known and we need larger studies for the same. For type 2 MED, in patients with coexistent horizontal deviation, you need to transpose uh, the resected muscle. Transposition of recessed muscle is said to weaken the effect of NAPS and can be avoided at times. For horizontal deviation less than 30 prism diopters, resection of single muscle and its transposition can be of help. For horizontal deviation more than 30 prism, patients are to be counseled for the other eye surgery. That means for the other eye you can plan for the inferior oblique total anterior positioning or a superior rectus recession in these cases. Thank you. Comments? Any questions?
Thank you, Dr. Gunjan. The most important thing is look for the Marcus Gunja winking phenomenon. Don't miss that. And look for the Bell's phenomenon. We don't want, when you're doing a ptosis correction, to go for overcorrection and then exposure keratitis and then re-releasing the whole procedure. So these are the two important things. We have done Nishida in one of the cases. 2 cases we have done.
Yes, 3 case report.
Long-term
Yes,
results.
long-term and larger.
Yeah.
I think the institute was the first to report 3 cases of JEPOs.
Yeah.
Yes.
So we have done that. It is the only thing is there is no involvement of we are not cutting off the blood supply to any of the things. So no question of any anterior segment ischemia, and it is reversible also. One time, it was a very 25 prisms, and the surgeon, one of my colleagues, she wanted to do, and okay, the next day we saw that it was overcorrecting. We simply released, and we got away with it. So that is one way it is good compared to transposition procedures or naps.
Moreover, we can plan in the same sitting.
Yes.
We don't have to wait for 3 months.
Yes.